Hi everyone, I am Dr. Praveen and with me is a very dynamic faculty of dermatology, Dr. Khushbu Mahajan. We have seen over the years that the exam questions have changed right from the pattern of a disease to an organ. So we'll take a question here and try to integrate the topics of dermatology and dermatopathology and understand how does the disease happen, at the same time how to diagnose it, but more importantly, how we solve a question. So let's start with it. I'll request Dr. Khushbu to read the question and tell you the options one by one.
So, the question that we decided for today's session was that we have a 50-year-old female who's presenting with blisters on trunk, arms and thighs. Now, the blisters are typically developing on an itchy red base and rupture in few days to leave a hemorrhagic base. Now, we have given you a clinical picture and direct immunofluorescence image of a patient. So, this is the clinical image where we are seeing the blisters which are happening and they're healing, leaving behind a hemorrhagic base. And here is the DIF image which is showing some immunofluorescence finding. So based on this clinical image and DIF image, there are some options that have been given to you and you have to tell us what is the incorrect option from the based on the condition which you will diagnose. So the options that are there with us is mucosal involvement may be present. Biopsy typically shows row of tombstone appearance. Nykolski sign will be negative and treatment options include steroid and dapsone. So as you can understand, we are talking here about blistering disorders and now in subsequent part, we'll clarify you how to diagnose and then mark the correct option. So, Dr. Praveen, over to you for the basic histopathology.
So, I hope that you might have thought of an answer here. Okay? And before you move to the further videos, try to make a diagnosis and try to mark an answer in your mind. Now, before we move forward, let's talk about the first year anatomy and histology. The first year. Ma'am, we have seen that the students, when they move to the first year MBBS, probably the most important part is histology, but that is where they lack the most.
Yes.
So let's start from there because that is the most basic thing in any MBBS career. And learning histology is fun, isn't it?
Yeah, and even so talking about dermatology, as me and Dr. Praveen were discussing, dermatopathology is the most important part. So if you can understand the basics of dermatopathology, I'm sure that you would be able to crack most of the dermatology questions because this is the only investigation we use in dermatology, which is pathology.
Yes. Okay, let's start with the layers of the epidermis. Now, if you look at these layers, you will always notice that there are stratum corneum layer, that is the topmost layer. It basically has a keratinization there. And then comes the stratum granulosum. You know why it is called as granulosum? Because if you look clearly, they will have some granules here. These are granules here, okay? And hence it's called a stratum granulosum. Below them is a stratum spinosum. A very interesting fact is spinosum has the word come from spinous process, and all the spinous process in the spinosum actually are what? They are the cadrens. They are the junctions which holds the two cells together. For example, if these two cells are together and if I hold them together, I have to put my two fingers together. I can hold it. So these all holding together appears as spinous process, and from that the word has come as stratum spinosum. Okay. Then comes the stratum basal layer. This is a stratum basal layer. Okay, and then there's a dermal papilla. Well, this is called as retirages. Okay, so often I have seen students getting confused, sir, how to remember the layers, which is top, which is below. Remember, G comes before S, so G upper hai, the G is top, and S is below that. Okay, stratum granulosum and then the stratum spinosum. Now, I told you, spinosum layer has the cells connected together with the help of cadrens. Have you ever seen a cadren? Cadren is just a desmosome. Okay, it's a protein of desmosome which holds the cells together. Yeah, the epidermis junctions. So I have brought this layer to make you understand. Let's understand. Suppose this is a cell. It's a epidermal cell, and you are trying to pull all the edges all in a separate direction, and these all separate direction would be by the other cells. That means if I put the cells here, if I put one more cell here, if I put one more cell here, if I put one more cell, so all these cells will be connected to each other by the spinous process, right? But let's assume the spinous process is lost. So what will happen? That this entire thing is gone, and because stretching effect is gone, the entire cell becomes this round cell called as, I hope you are all guessing it correctly, it is called as acantholytic cell. Because those pulling effect is gone, it becomes a round cell here. So this is called as acantholytic cell. Okay, so that is what is called as acantholysis, or called as loss of desmosome, loss of cadrins, whatever you want to name it. Cadrins are made of proteins called as desmogleins, which I'm very sure will be the hero of our today's discussion, isn't it? Desmogleins.
For sure.
Achha, let's understand the antibody being arranged in these layers. The layers are having desmoglein 1 and desmoglein 3. Again, just try to recollect the layers: corneum, granulosum, spinosum, basal. Now from top to bottom, the layers have the presence of the desmoglein 1 and desmoglein 3. So desmoglein 1 comes before 3, so 1 is at the top and 3 is before that. So 1 is majorly getting expressed on the upper surface, decreasing in the lower area, where desmoglein 3 is mostly in the lower area, decreasing in the upper area. So this is desmoglein 1, this is desmoglein 3. Let's assume there is a type 2 hypersensitivity in a patient. So I hope you remember type 2. Type 2 hyperreaction is a condition where the B cells of the antibodies are produced against a fixed antigen. Fixed antigen. Remember fixed antigen? So suppose the antibodies are formed against a fixed antigen. Here, these are antibodies. What will happen? All those desmogleins will be broken off. And that is when the cell shows acantholysis, and that is when it shows blistering disorders, which will be a clinical presentation, will be discussed by Dr. Khushbu in the next slides. But understand, once the cells are actually having destroyed by the antibodies, those cells lose the connections and the various types of lose the change in the cohesive forces. If the antibodies are formed mostly in the upper area, so the upper area will separate, okay? And where is the upper area? The upper area has DSG1. So when the antibody forms against DSG1, the splitting mostly is in the upper zones, right? But suppose the antibody forms mostly in the desmoglein 3, and where is desmoglein mostly? In the lower part. So if antibody forms here, the lower part will split off, and therefore we'll say it is supra-basal split. Now, I'm talking about desmoglein right now. I have not even talked about something which is in the dermal and in the lower areas. So right now we're discussing about the DSG1 and DSG3. Okay. So
I would just like to add one thing here. So as Dr. Praveen was telling you, so this, why do we get like desmoglein 1 is lower here? This is also called as desmoglein compensation theory. So in the lower layers, the desmoglein 3 will compensate for the function of desmoglein 1. So when we have antibodies against desmoglein 1, which is happening in Pemphigus foliaceous, my upper layers will be affected. Whereas when I have antibodies against desmoglein 3, which is happening in vulgaris, my lower layers will be affected. And now this thing kinds of reverses in mucosa, Dr.
Okay. Yeah.
So in mucosa, what happens is I have desmoglein 1, which is present only in the lower layers. So desmoglein 3 there is present throughout. So now in Pemphigus, when we are talking about vulgaris, so if desmoglein 3 is involved in mucosa, so definitely I'll have mucosal involvement because nobody is compensating there. Whereas if there is just desmoglein 1 involvement, which happens in foliaceous, so there my desmoglein 3 compensates, and that is why in foliaceous I will not get mucosal involvement. So this is a very, very important slide, I think, which if you understand, you would be able to understand most of the blistering disorder.
That's a very important point about the mucosal involvement and why does it occur and why does it occur in the Pemphigus cases. Moving ahead. So this is the type of split. We'll talk about this in a separate video altogether. Sorry, separate slides altogether. But understand that when this was corneum, right? And I hope you remember stratum corneum, then granulosum, then spinosum, right? So if the splitting is just below the corneum, we have to call this subcorneal split, right? Now, if the splitting is occurring just above the basal layer, you have to call this supra-basal splitting. But suppose the antibody is not formed against desmogleins, but is formed against something else. Now, what is that something else? So, suppose ये है epidermis और ये है dermis. Now, do you know how are they attached together? They're attached together by a collagen 7 attaching to the BPAG1 and BPAG2. Now, just imagine the antibody is not formed against the desmoglein, but is formed against the BPAG1, BPAG2. Then what will split? Epidermis will split to the dermis. So that is when this type of splitting will occur and is called as subepidermal. It's called as epidermal splitting. Now, I hope understanding this thing will be very, very important, because once Dr. Khushbu takes you to the journey of the entire pathophysiology, clinical features, and the treatment process, you have to keep these things in mind. So ensure you watch this part correctly and then watch the next part here. Dr. Khushbu, over to you.
So now we move on to the clinical part of blistering disorders. So what are basically blistering disorders? So see, blisters have formed, like we have studied in a lot of skin conditions that there is blisters formed. Now, what do we call them medically or clinically? They are called as vesicles and they are called as bulla. There are two main things, vesicles and bulla. These are fluid-filled lesions, vesicles which are less than 0.5 centimeter and bulla which is more than 0.5 centimeter. Now, vesicles and bulla are also formed in herpes. How are they different here? So here my vesicles and bulla are being formed because of some autoantibodies which, as we already told you, go and bind to a skin antigen, form antigen antibody complexes and cause a split there. Okay, so here the process, that is why we call these disorders also as immunobullous disorder, because here there is a involvement of my immune system, my own autoantibodies which are going and binding to an antigen present in the skin structure and causing the splitting. Now, as we already said, where the split is happening will define what my disorder will look like. So, for example, if we are talking about epidermis here, so if this is my epidermis, okay, and here below is my dermis. So now, if my autoantibody is going and binding to the antigens in the epidermis, which is my desmosomes, I will have a split which is there in the epidermis. So I will call them intraepidermal disorders. But if my antigens are going and binding to the antigens which are present in the basement membrane zone, then my split would be below the epidermis. So epidermis above, dermis below, and a split between. So this zone is called as dermoepidermal junction or basement membrane zone. So depending on where the antigen is located, I get a split which is intraepidermal if the antigen is desmosome, and I get a split which is subepidermal if my antigen is in the basement membrane zone. So the process remains the same. There is an antibody going and binding to the antigen. But which level of antigen it is, that determines whether I'll be having an intraepidermal split or a subepidermal split. And so that is why I classify my immunobullous disorders into intraepidermal and subepidermal disorders. So when a question comes to you based on the clinical and histopathological findings, you have to differentiate them broadly whether they are intraepidermal or subepidermal. Now understand, if it is an intraepidermal disorders, so here the split is happening in the epidermis. So consider that if this is my epidermis and I am having a split here, so my roof of the blister is just this. Whereas if I have a split here, my roof of the blister is this whole epidermis. So get this idea and then we move forward to the clinical scenario. So if it is an intraepidermal cyst, I have a roof which is little thinner. It is only a little part of the epidermis. Whereas if my split is below the epidermis, which is subepidermal disorder, the roof of the bulla is whole of the epidermis. Okay, with this basic thing in mind. So this classification you can read in the books and nobody actually asks you the classification. But broadly, you should know that intraepidermal disorders are called as Pemphigus group of disorders and subepidermal disorders are called as Pemphigoid group of disorders. If you ask me, the three most important conditions which are important for you is Pemphigus vulgaris, foliaceous and bullous pemphigoid. So if by the end of today's session you're able to differentiate between these three conditions, I think Dr. Praveen, our job is done.
Yes.
Right? So we'll talk about majorly these things.
In fact, I'll just add one thing. The meaning of the word vulgaris is most common. So if you're trying to remember it, vulgaris is most common, I think then you'd have to look at the meaning of the word vulgaris. Vulgaris itself means most common. It has to be most common.
Yeah, exactly. So here we'll talk in more of a case-based approach. So if a patient is there with you, if there is a question or a patient comes to you, how do you approach a patient who has come to you with vesicles and bullae? So obviously, when we talk about this, so you have to first reach a diagnosis. And how will you reach a diagnosis? It would be based on history, examination, bedside test, lab investigations and management. So even if you look at the question that we gave you, a typical case scenario, this is what we are trying to give you and trying that you can decipher an answer based on these steps. So coming first to the history part. Now, why is the age important? Now, remember, age is important for you because bullous pemphigoid always occurs in more elderly age group, 60 to 80 years age group. My pemphigus group of disorders usually happen in middle age. So usually in 30 years to 40 years of age group. But again, there's a catch here. Whenever we are talking about Indian population, we see a younger age of presentation. Okay. But why am I telling you here? Whenever we'll be giving you a case of pemphigus, usually in the exam, you would get a middle-aged individual. And in bullous pemphigoid, usually they will give you an elderly individual. Then, next important thing, what are the sites of the lesions that you see? Now, Pemphigus vulgaris typically affects face, scalp, and flexures. It can involve whole of the body as well, but these are my typical sites. But the more classical distribution that I see is with Pemphigus foliaceous, where I see seborrheic distribution. So what is seborrheic distribution? The upper part of the body where my sebaceous glands are located. So face, scalp, upper trunk, upper chest. So typically whenever they are giving you a patient of Pemphigus foliaceous, you will see that they give you the upper part of the body. Never have I ever seen an exam question where PF has been given on lower parts of the body. So this is something which is very striking. Upper part of the body which is involved. In bullous pemphigoid, you see more of abdominal involvement, flexural involvement, trunk and thigh involvement. So they give you a picture, an image which is focusing more on these sides. Then, how do the lesions evolve? Now, as I already told you, a pemphigus patient will have the roof as only a little part of epidermis. So it will have a tendency to break more easily. Now, in that also, as Dr. Praveen said, foliaceous is just subcorneal. So just imagine a thin layer of corneum is forming the roof. So in Pemphigus foliaceous, the vesicle and bulla rupture within few hours of when they are formed. So much so that it's hardly visible when a patient presents to you. Because the roof is so small, it will rupture easily. Whereas in vulgaris, it will stay for few hours or sometimes 1 or 2 days. But if it is at a site of friction, it will again rupture easily. Whereas a bullous pemphigoid patient, a subepidermal patient, has a whole epidermis as roof. So there my bulla would stay longer. It can stay for few days. So depending on how long is it taking to rupture, you can make a diagnosis. Then a pemphigus patient typically will give you a history and you can even see that the bulla is extending. There is a peripheral extension of the bulla of the erosion. Now, why does that happen? As we told you, there are keratinocytes and they're bound by cementing substance. Now, they are getting separated. Not as soon as they get separate, we see a vesicle popping out. So, at some points, they become clinically apparent and the vesicles and bulla appear. But the surrounding keratinocytes are also gradually getting detached. So, a little pressure, a little force causes these erosions and bulla to expand. So there is a history of peripheral extension that you get in intraepidermal disorders, but that will not happen in subepidermal disorders because again the roof is the whole epidermis and so it will take time. Then another very, very important thing in history, whether the patient has mucosal involvement or not. That again we explained during our earlier slides. So Pemphigus vulgaris patient would in 100% of cases have mucosal involvement. It may be there at presentation or may appear later, but eventually patient is going to have mucosal involvement. Whereas a foliaceous patient never has mucosal involvement. Why? My mucosa has mainly desmoglein 3, which is not involved in foliaceous. So no mucosal involvement. A BP patient, a subepidermal bullous pemphigoid patient, can have mucosal involvement and that's roughly seen in 30% of the cases. Then, how do the lesions heal? Now, my intraepidermal disorders are superficial. So, they just heal with some pigmentary changes. Why? Basal layer has melanocytes. So, whenever my epidermis is irritated, my melanocytes also increase in number. I get pigmented areas. Whereas my bullous pemphigoid lesions would usually heal with hypo or depigmentation. Again, there is no scarring in them. Scarring occurs in other forms of subepidermal disorders. Then, what is the patient giving me a history of? Is there a history of burning or itching? In Pemphigus group, we usually get a history of burning sensation. We do not get history of itching. As compared to bullous pemphigoid, where typically we get a history of itching. In fact, in bullous pemphigoid, lot of times we have a pre-bullous stage where the patient presents just with itchy urticarial lesions. Now, why that happens? Because in bullous pemphigoid, there is eosinophil recruitment which is there. So, because of those eosinophilic spongioses and eosinophilic recruitment, these patients usually develop a blister which is present on an itchy base, on a red base, on an urticarial base. Okay, so in bullous pemphigoid, you can get a history of prodrome or a pre-bullous stage where the patient might tell you that there were urticarial lesions over which I have developed a bulla, or you see a bulla surrounding which you see erythema and patient typically tells you that it's very itchy. This history you do not get in intraepidermal disorders. Then that was about history. Then when you come to examination, obviously again you look for the distribution of lesions which we have already talked about, and then you would try to look at the vesicles and bulla, which are my primary skin lesions that I'm seeing in this group of disorders. So what kind of bulla are they? Are they flaccid or are they tense? What is flaccid? Flaccid is like an old grape, an old blown balloon. थोड़ा सा फुस हो रखा होता है जो. So my intraepidermal disorders are always flaccid. Again, the same reason. There is a little roof which is there. There's a little roof which is there. Whereas my subepidermal disorders would be usually tense because they have a thick roof over them. So presence of flaccid and tense. They will usually give this an exam. Flaccid blisters or tense blisters. Once you see this, flaccid, always think of intraepidermal. Tense, always think of subepidermal disorder. Then what is the type of fluid? In subepidermal disorders, there is some amount of dermal involvement. There may be some amount of blood flow which is there. So you get hemorrhagic fluid. You see hemorrhagic crusting, which is not there in intraepidermal disorders. And then obviously you can have some urticarial or eczematous lesions. So look at this image. Based on whatever we taught you, I think you can look at the image and tell me what I'm talking about. So this here is a patient of Pemphigus vulgaris. Why? What do I see? I see these flaccid bulla which are rupturing to form erosions. And these erosions, if you look carefully, are spreading peripherally. You can always see an extension to them. So when you see flaccid bulla, flaccid vesicles, erosions which are spreading, you think of Pemphigus vulgaris. Look at the image here. This is, what did I tell you? They always give you the upper part of the body. You do not see any vesicles and bulla because they've ruptured. So in Pemphigus foliaceous, patient typically presents just with crusted erosions. What I see is just crusted erosions in seborrheic distribution. This is the typical history that you will get. So only crusted erosions in seborrheic distribution with no mucosal involvement. In vulgaris, vesicles, flaccid bulla, crusted erosions with mucosal involvement. Now look at this. Now look at the type of bulla here. The bulla here is very different from what we saw in Pemphigus vulgaris. Here my bulla is looking tense. It's looking tight. And I am seeing a red erythematous urticarial lesion surrounding the bullous area. So this is a case of bullous pemphigoid where I see an itchy red base, tense bullae develop, and these bullae have hemorrhagic fluid in them. And when they rupture, since the fluid is hemorrhagic, the crusting would also be hemorrhagic crust. So, and look at the distribution. It's on the trunk mainly. The abdomen, thighs, upper trunk, these are the common sites that I see involved in bullous pemphigoid. And this is the prodromal stage where I'm seeing urticarial erythematous lesions. Then when we look at the patient, we think of a particular diagnosis, and then we do 2 bedside tests in this group of disorders. So one is Nykolski sign, which again is easy to understand if you understand the concept. So what is Nykolski sign? So in Nykolski sign, you apply a tangential pressure over a bony area. You apply a tangential pressure. Now, if I am applying a tangential pressure on my skin, nothing will happen, obviously. My skin is firm. My keratinocytes are bound together. But what happens in intraepidermal disorders? My keratinocytes are separated out. There is no cementing substance. So I apply this pressure and my skin splits off. So this will happen in my intraepidermal disorders because my keratinocytes are loose. So they will shear off. So I will see that when I apply this pressure, I develop an erosion here. I sometimes develop a vesicle here. I sometimes develop a bulla here. This tells me that though there is no clinically apparent vesicle there, but there is some disease activity going down. There are some keratinocytes which have already loosened up. It's only time that they would develop a vesicle or bulla which is clinically apparent there. So this sign tells me 2 things. It tells me that there is activity of disease which is present. And second, it tells me again that I'm dealing with intraepidermal disorder. Now, if there is a subepidermal disorder and if I try to do this, I cannot shear off the epidermis because my epidermis there is normal. My keratinocytes are tight enough. So this sign would be positive in intraepidermal disorders, and this always indicates activity of the disease. Okay. So Nykolski sign, always in the question, sometimes they give you Nykolski sign is negative, Nykolski sign is positive. That is in itself an indicator whether we are dealing with intra or subepidermal disorders. Next sign is bulla spread sign. This is less commonly asked, but we should be knowing about it. Now see, there is a bulla here. Now I mark that bulla using a pen usually. Now if I apply a tangential pressure on this bulla, again in intraepidermal disorders, my surrounding keratinocytes are also weak. So my bulla will spread. It will spread beyond the original marking. So this spread in intraepidermal disorders is usually angular. Now in subepidermal disorders, again if I mark the bulla, there is a whole epidermis. So bulla might spread, but the spread would be more rounded. So bulla spread sign may be positive in both, but in intraepidermal disorders, the spread would be more angular, and in subepidermal, the spread would be more rounded. But again, if bulla spread sign is positive, it tells me the activity of the disease. Okay. So these are some bedside tests and how we examine clinically. Now I would want Dr. Praveen to explain me that how do I further investigate these patients.
I have a few questions to Dr. Khushbu because I was listening to this so carefully. You know, and it's the first time I understood so much of clinical features. And honestly speaking, ma'am, if I would have been in second year and someone had taught me something like this, I think that's the best thing to happen to any MBBS student, right?
This integrated thing is, I think
that is the need of the day, because as we are saying about the next or whatever is going to come, it has to be an integrated session. It cannot be just a pathology. It cannot be solely a dermatology. My question to you here is, suppose there is, because most of the biopsies are taken by clinicians only. We often don't take a biopsy. We are happy enough to get a biopsy specimen to us. But let's assume, ma'am, there is a bulla. So a histopathology specimen is taken from a different site as compared to a Zank smear. So often in histopathology specimen, we need to look at what is happening into this area. Yahan par. But you know what happens is, if you take a biopsy for a IFA from this area, often it will not yield as much as desirable results because there are a lot of antibody and antigen reactions happening at this position. So often those IFA tests, we don't take it exactly from the bulla area, we take it from the surrounding area here.
Exactly.
So, the histopathology specimen at least should be taken from the site of the area?
So histopathology sample, we always try to take from a new a freshly formed bulla,
yeah,
because we want to see the split properly.
Yes.
Now, in DIF, we take it from the perilesional skin because there we are trying to find out the antigen-antibody complexes. Now, once the antigen-antibody complex forms and my cell splits, it will be difficult to see those complexes. Now, the formation of antigen-antibody complex is the primary event, and splitting is the outcome of that event. So now once the splitting has happened, there may be inflammatory cells there will be fluid there. So it is very difficult to find out those antigen-antibody complexes when we put the fluorescence label anti-antibody. Whereas in perilesional skin, as I already explained you, जो हमें दिख रहा है उससे बहुत कुछ आसपास हो रहा है. तो perilesional skin में अभी एक्टिविटी है पर इतनी नहीं है कि स्प्लिट हो गया. So वहां पे भी एंटीजन-एंटीबॉडी कॉम्प्लेक्स डिपोजिशन दिख जाता है. तभी DIF के लिए हम हमेशा perilesional skin देखते हैं.
So that point is very important, because once you actually, most of the clinicians also don't take a biopsy on the right side. So ultimately what we end up reporting is non-specific inflammation, which actually irritates the dermatologist there. Okay, let's talk about the Zang smear. So what happens is, suppose there's a lesion here, because you understand Zang smear, this usual technique was developed by a scientist whose name was Zang, and he developed this technique not exactly for the bullous lesion. He had seen this mostly for the infective lesions, the viral lesions. Right. It could be done for varicella zoster, it could be done for the herpes as well as. So chickenpox can also be detected by the Zang smear. So often a microbiologist can also do a Zang smear. So what we do there is, suppose there is a lesion as a bulla here or any lesion here. First of all, we have to break this. Okay. So after you break this, here this is broken. So with the help of I'll suppose this is a scalpel, so we'll just scrape this lesion here. Okay. Suppose a scalpel and this lesion, we just scrape it here. Okay. And what a scraping comes out, we have to collect this in a slide. So suppose this is a slide and I scrape this area here and put the slide here, and after I put this on the slide, I have to stain this with a Giemsa staining. Okay, Giemsa again is Wronowski staining. Wronowski staining has an advantage because it can stain both the basic area and the acidic areas. So after this, we have to first fix it. Fixation can be done either by air drying or can be done on heat, or just passing over the heat, and then you have to stain this by a Giemsa stain. But please understand that a Zang smear is not only done for a bullous lesion. It has to be done or looked into also for the other vascular lesions, which Dr. Khushbu, would you like to just point a few of them?
Usually, as you already said, we try to, Zang is basically a cytological diagnosis for us. So whenever we are trying to look at these cells or the changes in the cell, we can do a Zang smear. So in dermatology, we most commonly perform it for herpes group of disorder, herpes simplex, herpes zoster, and for all kind of immunobullous disorders.
So what do we get here is, as I told you, normally a cell should have, the cells should be together. They should be cohesive. This word is very important. So cells should be like this. Every cell should be cohesive among themselves. And when they're cohesive, the shape of the cell is something like this. These are how the squamous cells are arranged. There's a basic idea of identifying a squamous cells, and they should have a nucleus like this. Okay. They should have these granules as a keratinocyte. They should be something like this. And this I'm talking about in which layer? I hope you have understood. It is actually a granular layer or a stratum spinosum layer. But when you do a cytology and the cells have this completely roundish area, okay, like this, round, hai na? This complete round area, this is a nucleus which has got a big in size because ultimately it has lost all the connections. So cell has become round in shape rather than from taking its typical shape, which is a spindle in shape, as the squamous cell should look like. They have now become rounded there. And you see the basophilus cytoplasm has come to the periphery area. Okay, because this usual property of a cell, when it actually loses adhesion, every of this component of cytoplasm, they move to the periphery. So often we see this halo around the nuclear area. Okay, it's not a very common sign in this area. If you see a halo, better to mark human papillomavirus, not this one. But yes, the cytoplasm is mostly basophilic in the peripheral areas, and the round cell is called as acantholytic cell. The whole property is being called as acantholysis. In simple word, it is called as a loss of cohesion. So as soon as a pathologist reports acantholysis, the clinicians, he think about, yes, there's some splitting off going on there, and based on this we can then do the histopathology specimen. Before we move ahead, let's discuss this table. Dr. Khushbu, would you like to talk about this?
So the whole idea of putting this table was that till now, whatever we have discussed, then using those points, you can actually differentiate the Pemphigus group and bullous pemphigoid. So age, as I already explained, you see elderly age group more in bullous pemphigoid. Then the size sites which are involved. Abdomen, thighs, they're more common for BP, whereas in Pemphigus vulgaris, you see scalp, face, body, flexures, and in Pemphigus foliaceous, you see seborrheic distribution. Then what type of blisters are you seeing? Are they flaccid? Are they tense? Are they filled with clear fluid? Are they filled with hemorrhagic fluid? And how much time do they take to rupture? So that will differentiate. Then, are the erosions extending peripherally? If they are, we are talking more of intraepidermal disorders, whereas in subepidermal disorders, they will not extend peripherally. Then Nykolski sign, it will be positive in Pemphigus group of disorder and negative in bullous pemphigoi. Bullous spread sign would be positive in both the groups, but the type of spread would be different. And Zank smear again. So Zank smear will be positive in Pemphigus group of disorder. So again, Dr. Praveen, let me explain. So what are we doing in Zank smear, as Dr. Praveen said? So if this is my epidermis, and suppose this is the split that I'm talking about. So if we are taking the smear from here, somewhere here, right, Dr. Praveen? So I see separated keratinocytes here. And that's why I see acantholytic cells in intraepidermal disorders. In subepidermal disorder, the split is here. There are no keratinocytes here. So even if I make a smear, there are no separated keratinocytes. So I do not see acantholytic cells in subepidermal disorders, because acantholytic cells are nothing but separated keratinocytes. So if we do a Zank smear in subepidermal disorders, what we can see? We might see some eosinophils, we might see some neutrophils, but we do not see acantholytic cells there. Okay, so with this basic knowledge about the clinical examination, now we move on to the investigations where we do a biopsy, and there Dr. Praveen would enlighten us.
We'll talk about the biopsy as the two sites to be done a biopsy from. One is a histopathology specimen, as we discussed already, that is from the area of the involvement, and the IFA should be taken just around the area of involvement. Okay, this was already explained to you. Ab dekho, what is actually a Pemphigus vulgaris? Vulgaris actually is a supra-basal split. Matlab, I think the pathophysiology is now clear. So let's talk about the histology only. Stratum corneum, okay, granulosum, spinosum, and this is stratum basale. Okay, this layer is the dermo-epidermal junction. This whole layer from here to here is epidermis, and this layer is dermis. This clear? Achha. Now the antibody forming in the Pemphigus vulgaris is splitting this area from here. Okay. Now what happens is these all are stratum basale layer. They tend to arrange them together like this, and this appearance has been compared to a row of tombstone. This row of tombstone is something like this. This is a tombstone. Those maqbara you might have seen, and because it's typical appearance, 1, 2, 3, 4. This is called row of tombstone appearance. Okay, this is a very good image to understand this. As you see, the entire epidermis area has completely gone out, and we're not able to see this actually in a histopathology specimen most of the time. So these are the only basal layer. Because there's only basal layer, it's called a row of tombstone appearance. Along with that, if we are able to see the upper layer, they'll show us acantholysis. Now this will be called as what? It will be called as Pemphigus vulgaris. Why vulgaris? Because there is a supra-basal split there. Okay. If you talk about the foliaceous, so foliaceous means there is a subcorneal split. So this layer again, stratum corneum layer, stratum granulosum layer. Okay, and see every other layer has come below. Okay, every other layer has come below. So because this is actually called a subepidermal split. More importantly, this area will subcorneal split. More importantly, this will also show us the acantholysis, again because as Dr. Khushbu told us that the problem here is in the keratinocytes, which is actually the epidermal layer, because not a subepidermal layer. Okay. Now, perivascular infiltrate of eosinophils and neutrophils can be seen, and that is as the reason of the itching sensation that is often this disease produces. Moving on to the bullous pemphigoid, obviously it will has a tense bulla. So this you have understood. So if you take this lesion from there, so this entire layer is the epidermal layer. Okay, and the layer coming down is the dermal layer. What has happened is the fluid has been filled up in this layer, and hence it is being seen as a bulla area. The entire inflammatory exudates have come here. The exudates will be consisting of the neutrophils, eosinophils. Those eosinophils is what causes a lot of itching also.
Yes.
A lot of itching session is seen there, and these all are the edematous fluid. Okay, but more importantly, what has separated out is the epidermis and the dermis. Now, just to prove these facts together, we have to do one more test. It is called as the indirect immunofluorescence test. The basic idea of doing that test is to look as what is that type of antibody being produced, and more importantly, where is the antibody getting deposited. Two things, okay? Which type of antibody and where it's getting deposited. In most of these lesions, there is IgG type of antibody. Okay, there's IgG type of antibody. That's very important to understand. So, if we do a fluorescence test, it can be direct or indirect. The biopsy taken from the perineal lesions within 2 cm of the blister, as we discussed this also before that, and should be performed on a blister as the immunoreactants are often lost from the roof of the blister. So we often take it around the lesion, around the blisters. Right, yeah. Okay. Now, देखो, if these reactions are being produced in the epidermal areas, so every of suppose this, I'm just marking the cells. Let's assume this is one cell, this is one more cell, these all are other cells, okay? So now see, these all cells will have what? The desmoglein 3 and desmoglein 1, depending upon the site it is actually present. The antibody are produced being against the desmoglein 3 and desmoglein 1. More importantly, when we talk about the Pemphigus vulgaris, the antibody mostly are throughout these lesions, and those are against desmoglein 3. Right? So because it's desmoglein 3, the entire epidermal areas will show those immunofluorescence area. And that is what will happen throughout the cells, all around the cells. I will give a typical fish net pattern. Okay, this typical appearance is called as a fish net pattern. It's actually what? It is IgG antibody, and with the IgG always will come as complement C3 deposition. Now, very important to understand is that the bullous pemphigoid, now this is not an epidermal lesion, it's a subepidermal lesion, okay? So let's assume in this image, suppose this is the epidermal area, it's a dermal area. Now this is actually the dermoepidermal junctions. The point to remember here is these deposition are usually granular in nature. Now these deposition is of IgG, and the it's usually BPAG2 and BPAG1 against which these antibodies are produced, and all of those will deposit as a granular deposition in the dermoepidermal area. So that means this will never show you the fish net pattern because the antibody is not in the epidermis, it is in the dermoepidermal junctions. So this type of lesions at this area would be called seen in a bullous pemphigoid area. Okay, and now Dr. Kushi, would you like to just point out here what would you see in a dermatitis herpetiformis, because this actually looks also like in the same way?
Yes, so dermatitis herpetiformis, though classified under subepidermal disorders, it's very different from other subepidermal disorders. Like you do not see any vesicles and bulla there. What do you see in DH? You see itchy excoriated papules. So it clinically mimics a lot of conditions. So sometimes you need to do a DIF to differentiate DH from other similar looking conditions. So the DIF of DH is also very different. So what do you see in that is, so if this is my epidermis, this here below is my dermis, and this is my dermal papilla. So this invaginations of dermis into the epidermis is dermal papilla. So in DH, I see fluorescence, which is typically located here, which is called as papillary tip immunofluorescence. Now, there is a lot of debate as to why that is happening, but we still do not have the clear answers. The antigen definitely is transglutaminase. So some people think that probably it is located up in the dermal papilla. But if you do a immunofluorescence, we do not see this linear or granular pattern. What we see is just papillary tip immunofluorescence in dermatitis herpetiformis.
Now, this is again a bullous pemphigoid, and now this is the EM image. It hasn't asked as of yet, but yes, this is the epidermal area. It's a dermal area. Okay. Now, what you see here is this is the hemidesmosome. Now, this can be an image-based question looking at a histology assessment. Okay, it's a hemidesmosome. Now, hemidesmosomes are those junctions between the dermis and epidermis. And if you look at this light layer, it's a lamina lucida, and the dark layer is lamina densa. Okay. Now, these are the anchoring filaments. Anchoring filaments also produce some antibodies. We don't have a discussion right now, but those antibodies are also there in some of the diseases. But what is happening is this epidermis and dermis are getting splitting off. They all are getting splitting off, and the reason of that is the antibody forming against the BPAG1 and BPAG2, and that is the basic pathophysiology of the bullous pemphigoid. The few other diseases that we have already discussed here, there's linear IgA, Dermatitis herpetiformis, and the difference is, as Dr. Khushbu said, that there is a linear deposition of IgA along the base membrane in linear IgA disease, whereas there's a granular deposition of IgA in the dermopapillar area in the Dermatitis herpetiformis. About the clinical features, would you like to add something here, ma'am? For these two?
So Dermatitis herpetiformis, I already told you, you get itchy excoriated papules. In linear IgA disease, you typically get an appearance which is called a string of pearls appearance. So you have a lesion and you have a bulla which is appearing as string of pearls at the periphery of the lesion. So that is typical of linear IgA disease. When linear IgA disease happens in children, we call it as CBDC or chronic bullous disease of childhood. So here, as Dr. Praveen told you, that there are IgG depositions that we have seen till now. But in linear IgA disease, as the name suggests, I will have IgA deposition along the basement membrane zone.
ELISA test can be done. Usually, it is not very commonly done though, because these are usually diagnosed in histopathology and the IF is more than sufficient to diagnose the disease. But yes, one can go for these tests also. Having understood so much about, pathophysiology, clinical findings, and it must be very much interesting now to treat the disease. I think most of the students who actually they will literally love to go to the dermatology ward and try to see how the disease looks like.
Yeah.
Now, once you look at the disease, let's try to understand from the clinician points of view how to treat the disease.
So, management of this group of disorders is a whole lecture in itself, because so much is happening, so much can be done to revert it. So I'll be very brief here depending on what is asked for you. So remember, as we already told you, it is an immunobullous disorder. There are antigen antibody complexes being formed. So I need to suppress my immune system. So my mainstay of treatment would be giving you an immunosuppressant. Now, the best known immunosuppressant is steroids. So steroids, though people think that we should not be giving steroids here and there, and a lot of people have a lot of misconceptions, this is one group of disorders where we use steroids and we use high dose steroids, because there is so much of immune response that is happening and you have to stop it. The disease is much more inside than it looks outside. So Pemphigus group is a clear-cut indication where we give high-dose oral steroids. But these group of disorders we have seen, they are not short-term. We have to treat these patients at least for 2 years. Even when clinically the patient has improved, the patient has to be treated so that it doesn't relapse back. Now, you cannot give oral steroids for so long to a patient. So in these patients, we typically give high-dose oral steroid and combine them with other non-steroidal immunosuppressive agents, which can be azathioprine, cyclophosphamide, and mycophenolate mofetil. So we start both of them together. We gradually taper these steroids when the patient is controlled, and we maintain the patient on an adjuvant, which is azathioprine, cyclophosphamide, or mycophenolate mofetil. So that is broadly what we use in intraepidermal disorders. Whereas in subepidermal disorders, they're usually considered milder than intraepidermal disorders. So here also I use steroids, but a relatively lower dose steroids as compared to my Pemphigus group of disorders. And here I can even manage without an adjuvant, because I usually see that once you taper steroids, patients are okay. Dapsone is a group of drug which is very commonly used in bullous pemphigoid, because we see a lot of neutrophilic and eosinophilic infiltrate. So Dapsone works against them. Apart from that, you can use all the other adjuvants that we discussed, and you can also use nicotinamide and tetracyclines here. So this is the broadly. Otherwise, you have to give antibiotics, you have to manage the crusting, the infection. That patient should not develop a secondary infection. So there is a lot into the treatment aspect. But broadly, for your exam point of view, this is what is asked. So I think, Dr. Praveen, now we can go back to the question. And I'm sure the students would have an answer to it by now.
Let's try to read the question, because
Yes.
now let's see it from the clinical point of view.
Yeah.
A 50-year-old patient a 50-year female patient, she has blisters on the trunk. Now this is the important point for us, arms and thighs.
50-year-old.
Okay, 50 year is first point. This is the second point. The blisters typically develop on an itchy red base and rupture in a few days. Okay, now this is the third point. This is the fourth point. To leave a hemorrhagic base. Now, there are 4 points to be understood here. I hope you understood the entire video. Let's talk about and see these images again. So, lesion number 1 and 2 things to be seen here. Okay.
And I think we can
Okay,
point to
let's
these
point out
lesions.
these also. So what do you think? Are they ruptured? Aren't they ruptured? What do you say? Well, obviously these lesions, they are not ruptured.
And they're tense.
They're looking very tense. Yes. Yeah. Most importantly, if I just want to ask Dr. Khushbu, this lesion, this can be confused with a rupture. Vulgaris.
Vulgaris. So very commonly, vesiculobullous disorders are confused, and that's why I think we are talking about it right now. If it was so clear-cut, then we would not be talking about. And that is the whole idea of giving you a close-up image like this. So both vulgaris and pemphigoid would leave crusted erosions. It would be there in both the disorders. That is why the history is important. Did the erosion spread? How were the blisters? So then you look at the typical blisters. These are tense. In fact, Dr. Praveen, if this blister also gets old, it can become flaccid.
Okay.
So you typically ask the patient that how was the new blister which formed. So this is the idea of giving this close-up image where I'm seeing such tense blisters, and then I can see these crusted erosions, and we see a little red itchy base here, which is important. And then Dr. Praveen, I think this is a giveaway.
I think this we have this is a giveaway, right? This is completely giveaway. This is a area of epidermis. This is the area of epidermis. This is the area of dermis, and you can see very linear type of deposition in the area of the dermo-epidermal area. This should be an IgG deposition, and hence we can talk about our diagnosis, which is now bullous pemphigoid. Acha. Dr. Khushbu, let's try to read these options one by one and try to see which of the answer is actually correct.
Yeah. So we are here trying to find out the incorrect about the above condition. So the most important thing is diagnosing the correct condition, which I think with all the clinical and histopathological inputs, you should be clear with. So now let's look at each option. Mucosal involvement may be present. Now, whenever we look at mucosal involvement, you people think that this is Pemphigus vulgaris because you've been taught that vulgaris has mucosal involvement, foliaceous has no mucosal involvement. So a lot of times you see this, you think this is vulgaris. So remember, I told you bullous pemphigoid can also have mucosal involvement in 30% of the cases. So this, Dr. Praveen, becomes the correct answer.
Statement. Even though, whenever this option is made, like wants you to say, isko true hi maan lo.
I think you're right.
Okay. Next option.
Next option. Biopsy typically shows row of tombstone appearance. I think Dr. Praveen very elaborately and very clearly explained to you what is row of tombstone appearance. And now you know that this is involving my basal cell layer. So not the basement membrane zone. This is involving the basal layer of the epidermis, which are separated, which are appearing at tombstone. And so this is seen in Pemphigus vulgaris or intraepidermal disorder and not in bullous pemphigoid. So this is not the correct answer. Coming to the third option, Nykolski sign will be negative. Yes, it will be negative because here the bulla are tense. They are subepidermal. So my Nykolski would be negative. And treatment options include steroids and dapsone. Yes, steroid is used in both vulgaris and in pemphigus and subepidermal disorders. And dapsone also can be used in pemphigus also, but is more commonly used in bullous pemphigoid. So I think the options are very clear now, and I think we can make out that option B is my incorrect option because that will be seen in intraepidermal disorder, and the clinical image and DIF that we gave you was for subepidermal disorder.
So thank you guys. I hope it was fun watching and it was fun learning a lot. I personally learned a lot today.
I think both of us did, and it was fun to teach together. Yes. What do you say, Dr.
Completely true, because I think this is what is lacking in the system, and maybe if you can learn in this way, nothing can beat you in these disorders. Waiting for your comments, and whatever you feel like, do write to us and let us know how do you like this lecture. If you want to learn anything extra from us, do message us also. We can put that in the next video, upcoming video. And wishing you all the best from both me and Dr. Khushbu. Take care. God bless you all and stay happy.
As we always say, we want you to crack your PG entrance exam, but most important, be a good doctor. And I think this integrated teaching can help you become one. Right, Dr. Praveen?
Sure.
Okay.
Thank you.
Thank you so much.